Hello class, we're going to have several PowerPoint presentations as VOPs covering antibacterial agents. My reference is the pharmacology book, which is the pharmacological basis of therapeutics, the Goodman and Gilman book that you can have access through the Access database online. And let's get started. Few definitions really before we dig into the antibacterial agents. Well, you may have noticed that in every pharmacology books, even the one that you go over in preparation for the USMLE exams, the chemotherapy chapters are very much close to the antimicrobial chapter. What I mean by the chemotherapy chapters, if I want to be more accurate, are the drugs for cancer or the cytotoxic drugs. Now, I am used to use the term chemotherapy and many others only for cancer, but this is not 100% correct because really chemotherapy is a broad term that covers not only cancer therapy but also antibacterials, antifungal, antivirals, etc. Why is that? Let's go over the definition of chemotherapy. Well, this is the treatment of disease using chemical agents or drugs that are selectively toxic to the causative agent, being a virus or any other microorganisms or even the malignant cell. So really, the most important term here is selective toxicity. I want to be selectively toxic to the virus. I want to be selectively toxic to the bacterium or to the cancer cells. Obviously, we try to be selectively toxic to malignant cells by targeting certain mechanisms, but it doesn't work as beautifully as with bacteria because malignant cells are coming from us, from the host cell. Whereas for the bacteria, we try to be more selectively toxic by targeting some mechanisms that are peculiar to those microorganisms. Typical examples are the beta-lactams that target the cell wall, and obviously we do not have a host cell wall. So this is the broad term chemotherapy, and under chemotherapy there are the cytotoxic drugs for malignant cells, and there are also the antimicrobials. What are antimicrobials? Those are drugs that target infectious agents, and those infectious agents could be fungi also. And the specific word antibacterial is for the bacteria, and this is what we will be covering in those very first 5 sessions. And then another less broad term is antibiotic, and I many times use the word antibiotic, sometimes incorrectly because I'm used to, but if I want to be accurate, an antibiotic is an antimicrobial. However, it is produced by other microbes, and the typical example that comes is penicillin, right? Penicillium coming from a fungus, and so penicillin is actually antibiotic. We have several classes in penicillins, some of which are synthetic, some are semi-synthetic, etc. But the original penicillin that was discovered by Alexander Fleming, coming from the fungus, is an antibiotic. And another example, Pasteur and Joubert in 1877 discovered that, anthrax bacilli grew in sterile urine but not in urine containing bacteria. And this is when we said, so bacteria can kill bacteria. Some bacteria may secrete some antimicrobial chemicals, and to be more specific, we call them antibiotic. So keep those 3 definitions in mind. And I do like history, and I think that antibacterials and antimicrobials lend themselves into history. And today we take a lot of things for granted, but there was a lot of research done very early in the early 1900s to discover antimicrobials. This is the time of the war. We had a lot of wounded soldiers coming back and with a lot of infections and gangrenes, and we needed to target bacteria. We needed to target Staph aureus, for example. We needed to target strep infections, and we needed antimicrobials badly. So there were a lot of people trying to do that. Among them is Paul Ehrlich, who mostly worked with organic arsenals and azo dyes. So that started in the dye industry. But then they said, well, why don't we try those drugs, see if they have any antimicrobial effects? And they did a lot of experiments, and I'm just putting some results that they had here. Of course, not for your memory, but just for fun if you want. Well, they said, some synthetic organic compounds can cure infections, not only the ones coming from natural sources such as penicillin coming from fungus. Well, some can cure infections, and you will see the sulfonamides coming actually from the azo dyes industry. Sulfonamides being antifolates. And then they did some systematic exploration of structure-activity relationship. What do I mean by this? And you know it already, that you need a certain structure to work on a certain receptor. Not any structure would work, and if you change the structure a little bit, you may change the efficacy, you may change the pharmacokinetic parameters, etc. They used standardized infections in animals, so they started animal experiments, and they wanted sharp and reliable endpoints. You see, so they started systematic research, which is now we take for granted. The aim is to raise the chemotherapeutic index, and that is to try to be as effective as possible with the least toxicity possible. We talk about the receptor theory, and also at the time they coined the term drug resistance, and they discovered that it is the organism, the infecting organism, being resistant and not the host being resistant, and this can happen to a class of antimicrobial and not the other. So all of those, they were being experimented and discovered, and this is the time when people really needed antimicrobials at the time of the war. And again, Paul Ehrlich is very important to mention, and he received the Nobel Prize, and he actually coined the term selective toxicity. And what he said at the time is that we want a bullet, and that bullet is the antimicrobial, and we want to shoot the person with that bullet, but we don't want the person to die, but rather the microbe to die, the parasite or whatever, and that is selective toxicity. We want to learn how to shoot better. Okay, enough history for this voiceover PowerPoint. How do we classify antibacterial? So there are several ways we could classify antibacterial, and each book does it differently. One way is to do it by the chemical structure. Another is by the source, being natural versus synthetic versus semi-synthetic. Another one is by spectrum of activity. And what I mean here is that some antimicrobials would cover, for example, gram-positive bacteria only, others gram-negative bacteria only, other gram-positive, gram-negative, and atypical bacteria. Some, although they cover gram-negative, but they do not cover, for example, Pseudomonas aeruginosa. So the more coverage, the wider the spectrum of activity. The less coverage, the narrower the spectrum activity. So we have a narrow spectrum and a wide spectrum. Another way is to differentiate them into bacteriostatic versus bactericidal antimicrobial. And bacteriostatic meaning that the drug stops the bacterium from growing, whereas bactericidal means that the drug kills the bacterium. So now you would ask yourself, well, is it okay to give a bacteriostatic drug to a person who has an infection? Is it enough to stop the growth of the bacterium? Don't we really want to kill the bacterium? And the answer would be, it depends. But by the way, I'm going to use a lot the word it depends in antimicrobials, because it depends on a lot of things. And here, it depends on the host. If my host is okay, is young, immunocompetent, I'm okay giving a bacteriostatic antimicrobial to stop the growth of the microbe, and then the immune system will kick in and kill the bacterium. Whereas if I am dealing with an immunocompromised patient, how about a patient who has cancer and came to the hospital with neutropenia, then definitely I do not want to give a bacteriostatic drug. I want to give something that kills the bacterium. The host does not have a good immune system to kill the bacterium. So really, it depends. And finally, there are books that classify the antimicrobials by mechanism of action, and this is how we are going to do this in our set of slides. So here comes this picture that looks busy, but by the time we finish our VOPs, you would know every single thing. And this is really the outline. And how are we going to do this? So remember, we are doing selective inhibition. We are selectively inhibiting certain target in the bacterium. So let's imagine this circle being the bacterium. And we're going to start with the inhibitors of the DNA synthesis and integrity. We will start after this introduction with the sulfonamides and trimethoprim, being inhibitors of DNA synthesis, and also we call them antifolates. And then we're going to move to quinolones, being inhibitors of DNA integrity, as you will see later. And then we're going to move to the peptidoglycan cell wall inhibitors, and here are some of the drugs, and again, don't worry, you're going to remember them all. And we will start with the beta-lactams and then the non-beta-lactams. And then finally, we're going to move to the inhibitors of ribosomal inhibitors. And we will start with the aminoglycosides, and then we'll talk about others. So this is really a picture, a busy picture, but this is about the outline. Now, before we start with the classes of drugs and we talk about each one of them, the mechanism of action, etc., let's cover some basic principles of antimicrobial therapy. Now, you may know already that we have a specialty in the hospital, and that is infectious disease. We have infectious disease experts. And this is because in infectious disease, the point is not to only look at the antimicrobial spectrum of activity and choose the one that targets the bacterium and that's it. It's not that simple. There are many other factors that one has to think about. And it's beautiful, by the way, to discuss antimicrobials and make a choice. Well, let's go over some of the principles. So there is a difference between in vitro and in vivo susceptibility. So you may do the test in vitro using the agar or the strips or whatever that Dr. Matar has taught you, and you see, well, there is in vitro susceptibility. This antimicrobials works well. However, in vivo, it may not be the best choice. Why is that? For many reasons. One could be the host. Maybe the host has some genetic factors that makes him or her that will lead to less success of the antimicrobial. One example that you may remember, the acetylation, the fast acetylators and slow acetylators with the NAT enzymes and isoniazid being the antituberculous drug. Well, maybe for that specific person, it's not a good idea to give this drug because it won't work. Age also. Sometimes a drug could be contraindicated in children, and you will see with me that quinolones are contraindicated in children because of the risk for joint problems and tendon rupture. Maybe the person is too old and has kidney disease, and that drug is nephrotoxic. And you will see some drugs that are nephrotoxic, and you don't want to give to this person, although it covers beautifully the bacterium. In addition to host, you want to think of local factors. If the person has an abscess, and a typical abscess that you can think of is the dental abscess, kharaj. Well, the first thing you want to do with an abscess, actually open it. You want to drain the abscess. Now, what is the problem with the abscess? Why is it hard to treat the bacterium that are inside the abscess? One is poor vascularity. The antimicrobials may not reach nicely the abscess. And two, you have anaerobic conditions. And you will see that some antimicrobials have to go inside the cell to work. Maybe ribosomal inhibitors, they need to go inside, and some antimicrobials need transporters to go inside the bacterium, and you know transporters need ATP, they need oxygen, so in anaerobic conditions that won't work. Other local factors, prosthetic materials. If the patient has a knee replacement, a hip replacement, God forbid if it gets infected, because this is really hard to treat, and at times we need to remove the prosthesis. If a person has a valve replacement and it gets infected, then also there is a chance that we need to remove the valve. Why is that? Because prosthetic material promote formation of a bacterial biofilm, so the bacteria sit on it, and that leads to impairment of phagocytosis, so the immune system cannot kick in. And two, the bacteria grow much slower. And I failed to mention a very important principle here, and that is by the mere fact of the bacteria being actively growing makes them more susceptible to the antimicrobial drugs. For instance, if we are dealing with the antifolates that we will discuss in the second VOP, those are DNA synthesis inhibitors. Well, they would work more on the cells if they are actively growing. If a cell is not growing, then who cares about DNA synthesis, right? Or for the cell wall synthesis or protein synthesis. So this is why the more actively growing the bacteria are, the more susceptible they are. So with the prosthetic material, you would have a slowly growing bacteria, so they make them less susceptible. And a typical microbe that you can think of is Mycobacterium tuberculosis. It grows slowly, and this is one of the reasons that makes it harder to treat. Additional factors that we can think of are pharmacokinetics. There is an additional slide after that for more examples on pharmacokinetics, but the example here that I have is formulation. I don't know, maybe you want to give a drug to a child, and this drug is given PO, and the child is nauseated and vomiting all the time, and you simply cannot give this drug, etc., etc. Some pharmacokinetic factors. Remember, the purpose is to reach the adequate drug concentration at the site of the infection. And again, sometimes you have a beautiful in vitro susceptibility, but you may have in vivo resistance. Maybe the minimal inhibitory concentration is too high, and hence it's really hard to reach it in vivo, so you just can't do it. It's in vivo resistance. Sometimes the opposite is true. So sometimes you may have in vitro resistance, but in vivo it will work. An example is if we are dealing with a urinary tract infection, and this drug is renally excreted as an active drug, and hence it concentrates in the urine. So although we need a very high minimal inhibitory concentration, we can easily reach it in the urine, and hence this drug can be used for UTI beautifully. Now let me talk about meningitis and the blood-brain barrier. You already took the blood-brain barrier. There are several factors that constitute it. For example, could be the transporters, could be the tight junction, etc. When a patient presents with meningitis, an infection in the meninges, which is a very serious infection, by the way, this will lead to less tight junctions, and hence the antimicrobials and the polar ones, such as penicillin G, can more easily cross the blood-brain barrier when there is infection versus when there is no infection. So what is important here is that as your patient improves, as the meningitis hopefully resolves, you really do not want to decrease the dose of penicillin G. You want to keep it the same because as the patient improves, your blood-brain barrier improves, and less penicillin G will be able to cross it and go to the brain. Now, don't get me wrong and think that every time we have an infection, as the infection improves, we decrease the dose. No, we don't do that all the time. Sometimes we do. It depends on the infection, it depends on the host, it depends on the drug, it depends on the renal function, etc. But the point that I'm making here is that if we are thinking of decreasing the dose, definitely we don't want to do that in this case because the blood-brain barrier is improving and less penicillin G will be able to cross it. And I put here nitrofurantoin as a typical example of an antimicrobial that highly concentrates in the urine, both the parent and the metabolite. And this drug really, we keep it for urinary tract infections. And it is bactericidal in urine at therapeutic doses. It doesn't work well for other bacteria except if they are in the urine. Now, how does it work? There are several mechanisms of action for nitrofurantoin. It inhibits ribosomal proteins and hence inhibits protein synthesis. Also alters aerobic energy metabolism and also alters DNA, RNA, and cell wall synthesis. So there are several mechanisms, but we keep this drug only for urinary tract infection because of the pharmacokinetic advantage being renally excreted. Other principles, we sometimes tend to combine antimicrobials. Sometimes we don't give only one antimicrobial, combine them. And at times we have additive effects, at times we have antagonistic effects, and at times we have synergistic effect. Of course, we don't want to combine drugs with the antagonistic effects. We want to try to have an additive or synergistic. Let me try to explain. How about you think of this question a little bit? If we combine a bacteriostatic with a bactericidal drug, what happens? And yeah, the effect would be antagonistic because we talked about the basic principles of how those drugs work. They would work better if we have a bacterium that is actively replicating. So if we give a bacteriostatic antimicrobial that inhibits growth, then the effect would be antagonistic. So you would ask me, so doctor, we never ever combine a bactericidal with a bacteriostatic antimicrobial? Well, the answer is, guess what? It depends. It depends on what is your aim. If your aim is to have a synergistic effect on a certain bacterium, so you think that this person has a certain bacterium, bacterium A, and you want to hit it strongly with two antimicrobials, then you want a synergistic effect or an additive effect. You don't want an antagonistic effect. But at other times, you may not know 100% what this person has, what bacterium is causing this infection. And this happens many times. We have a patient who gets admitted with fever or pneumonia or whatever, and we don't exactly know what bacterium is causing it. We guess, of course, from taking history, etc., we guess what bacterium it is, but we're not 100% sure. So what we do is we take cultures, and the culture, the results to be out, they need at least 48 hours. And while waiting for the culture, we have to start with an antimicrobial. So we don't know, does this patient have a gram-positive, that patient has gram-negative infection? We may give a combination, and in here it's okay if we have an antagonistic effect because we don't care, because one of the antimicrobial is targeting the gram-positive, another one is targeting the gram-negative. We're not targeting the same bacterium. And of course, you want to make sure that your patient is immunocompetent, otherwise you don't want to give a bacteriostatic drug. So here comes the second slide that I alluded to a little bit. When do we give combination antimicrobials? So one of them is the example that I just gave, empiric therapy for infection in which the case is unknown. So I don't know what this patient has. And the term empiric is to give something and I don't know what the bacterium is. Again, we have some guesses, and of course we have to take culture before we start anything. At times we have polymicrobial infection. A typical example is a diabetic foot, a patient who has long chronic diabetes and comes with an infected foot. It could be staph, it could be whatever, it could be anaerobic bacterium, so we may want to target more than one. And Of course, the example that I also mentioned before is when we want to enhance antimicrobial activity against one organism, and here we want an additive or synergistic effect. Of course, there are problems. A basic principle is to give the least antimicrobials possible because of the problem of resistance. Dr. Matar mentioned it, and I'm going to mention it again here, and I think repetition is good. So we want less antimicrobials. Another problem with that, you will have increased toxicity. And here for toxicity, we can argue both ways. We can say maybe I have less toxicity. Maybe because those two antimicrobials are synergistic, then I'm going to have to give a lesser dose of this one and a lesser dose of this one, and hence less toxicity. Yes, but also you would have the toxicity from this one and this one, the new ones, if you want. So toxicity, you may have additional toxicities, one from each, and probably less toxicity if we are giving a less dose. Maybe we're not giving a lesser dose. So this is a little bit uh, uh, tricky here. I hope you got the point. Of course, increase the cost. We're giving two drugs. Another thing that I want to point out here is super infection. And this can happen with any antimicrobial. It doesn't have to be a combination antimicrobial, so it happens with any antimicrobial. However, it happens more if the antimicrobial is broad spectrum or if we're giving combination antimicrobials. What is happening here is that, okay, we're killing the bacterium that is causing the infection, but at the same time, we're killing the bacteria, the normal flora. We have bacterium, as you know. We have it everywhere. We have it on the skin, we have it in the GI, we have it in women in the vaginal area. And the typical example in the vaginal area is we kill the bacteria, and what remains there are the fungi, and for example, candida. And I'm sure you've heard or you experienced, if you are a lady, you take an antimicrobial for tonsillitis or whatever, and then suddenly you develop a vaginal candidiasis, and the symptoms would be itching and cheesy whitish discharge. So this is not a new infection. The candida was there, but it did not have enough space and nutrients to grow because there were bacteria around it from the normal flora. But now that the normal flora has died from the antimicrobial, the fungus is going to flourish because obviously we gave an antibacterial that would kill the bacteria and not the fungus. So this is what could happen with the combination antimicrobial, and I alluded to that, the resistance, the acquired resistance. So the term acquired here means that the antimicrobial may be initially working against a certain bacterium, but then with time we have a resistance. And remember the principle of Paul Ehrlich, resistance is because of the bacterium and not the host here. And what's happening, this happens obviously again with the broader the spectrum, the antimicrobial, the more we have resistance. This is why we want to try as much as possible to target the bacterium. If we know that we have a Staph aureus infection, I want to choose something that targets Staph aureus. I do not want to give something that targets Staph and Strep and E. coli and Pseudomonas and whatever. I want to be the most specific possible, because the more targeted, the better. We don't kill other drugs and lead to more resistance. So how do we have this acquired microbial resistance? It's a mutation that happens, and again, also here I want to point out that it's not the antimicrobial that touches the DNA and leads to mutation. No. Remember, those are actively replicating bacteria, and every time you have something that is actively replicating, there's a chance for mutation to happen. And here it so happened that by actively replicating, one of the mutation is actually resistant to the antimicrobial. And the mutation types could be the drug does not reach its target, there's drug inactivation, and you will see examples of that, or the target modification. If the target is a certain enzyme, then it may also be mutated and the antimicrobial does not work. How is acquired microbial resistance transmitted, if you want? Vertically or horizontally. Vertically, meaning from the bacterium that just developed resistant down to its daughter cells, but this is the least common. This is slow but least common. Unfortunately, the most common is horizontally, and this is the problem. When you have a bacterium that develops resistance, and then this resistant factor can be disseminated to the bacteria that are similar, but it can also go to other strains. And also sometimes we have MDR, multi-drug resistance. How is this transmitted horizontally? By transduction, transformation, or conjugation, and conjugation being the most common one. And the problem with that is that we have a piece of DNA being transmitted from one bacterium to the other, and that piece of DNA can transmit more than one resistance factor. Maybe it can transmit a resistance factor to beta-lactams, to cephalosporins, and also to fluoroquinolones that you will see with me in a minute. So there's this risk of multi-drug resistance, and this is fast and this is problematic. Now, how is this happening? Why are we having drug resistance? Well, it's written here. We are creating selection pressure favoring growth of resistant strain. Basically, I told you that the mere fact of those bacteria being actively replicating will, by chance, you will have a mutation, and that mutation would lead to resistance to a certain antimicrobial. So you would ask me, so why we don't have resistance all the time? Well, when the cells are actively replicating, but they are constrained in a certain milieu with other bacteria around them, there isn't enough place for them to grow and enough nutrition for them to eat and grow. However, when you use the antimicrobial, you would be killing a lot of them, and hence this bacterium that by chance is resistant will have enough space and nutrients to flourish. And this is why I said the basic principle is to give the most narrow spectrum antimicrobial possible, because you want to kill the least bacteria possible. You don't want to kill everybody and let this resistant bacterium flourish. So never forget, you want to give the most narrow spectrum antimicrobial possible. Also, another thing is to talk about combination antimicrobial. I just explained that one. When do we have drug resistant microbes? Broad spectrum antimicrobial, I have this green question mark here, and for me it's a way for me to remember that when it's green it's increase. So broad spectrum antimicrobials increase the risk of drug resistant microbes. Now, how about combination antimicrobials? So here really it depends, and I talked a little bit about it before, but I did not explain it at length and well. With combination antimicrobials, hopefully, maybe we'll be decreasing the risk of drug resistance. And again, it depends. If I am using a combination antimicrobial against a certain microbe, one microbe, I'm not giving the combination antimicrobial to target just anything as broad spectrum, or to target two different microbes. No, if I'm using it for synergism or additive effect, then the risk of having resistant microbes to both drugs that are targeting the same microbe is going to be harder. And this is usually the case. And a typical example of the use of combination antimicrobials where I want to actually decrease the risk of resistance is the treatment of tuberculosis with multiple drugs. You're going to see tuberculosis with me. The treatment of tuberculosis is a little bit harder than other bacterial infections. One of them we mentioned earlier, and that is that the bacterium may sit and be dormant and not be actively replicating. And another one is drug resistance. And one way to decrease the risk of resistance is by giving combination antimicrobial. And so what are we doing here? We're targeting the same bacterium. And also for TB it's even easier because it turns out that mutations in tuberculosis happen spontaneously and go vertically. Remember we talked about the two mechanisms being horizontal and vertical. Well, for TB it's mainly vertical, so it is slower. So once you have a mutation in one, then you would have resistance to only one drug. And let's say that the rate of mutation is 1 in every 10 to the power 8 bacteria. When we have a bacterial infection with tuberculosis, the burden is more than 10 to the power 8, but less than 10 to the power 16. And if the rate of mutation is 1 in 10 to the power 8, if you give 2 drugs, then the risk is going to be 10 to the power 16, right? The probability, I'm talking about probability. And hence, if you give 2 drugs, you're going to be in between here, and hopefully the bacterium is going to be dead and taken care of by one of those 2 drugs that we are giving in combination. And the last 2 slides, not for your memory, but it's important to recognize that we are trying all the time to prevent antimicrobial resistance. You don't want a patient to be admitted to the hospital with a certain bacterium and this bacterium is resistant to every single antimicrobial we have. So what we can do is prevent. We try to vaccinate so that the person does not come with an infection. Get the catheter out. You will see a lot of your patients who are admitted and they need a catheter, for example, a urinary catheter, a Foley. Well, you want to get this Foley out ASAP, otherwise it will get infected. So I want to prevent the infection. I want to diagnose and treat the infection itself. I want to target the pathogen. I've said it so many times. I want to give a narrow spectrum that targets the pathogen. Of course, I want to access the expert, the infectious disease experts in the hospital. When I decide to use antimicrobial, I want to be using it wisely. There are a lot of rules and regulations in the hospital to practice antimicrobial control. For example, I cannot just choose any antimicrobial I want. I have to access the expert, consult, and make sure I'm choosing the right one. I use local data, and we're going to see this together in our TBL, and I uploaded it on Moodle. We have this local data being released from AUBMC and every single hospital every year, and it tells you that this bacterium is sensitive to this and resistant to that, so that you can use this data and choose wisely. We want to treat the infection and not the contamination. Many times we ask our patient to do a urine test, and if it's a woman and the woman does not take a clean catch, then we may have epithelial cells in the urine, and we may have a bacterial infection, but it's not real. It's contamination from the skin. So I really want to make sure that this is actually an infection rather than a contamination while taking the sample. I want to say no to vancomycin is an antimicrobial that you will see with me. It is very specific for a specific type of bacteria, and I want to use it all the time. And I don't want to treat forever. I want to stop at some point, because if we keep on treating, we're killing more bacteria and there's a higher chance of having resistance. And finally, prevent transmission. And this is why in the hospital all the time we have to break the chain of contagion. We wash our hands between patients. We don't just touch one patient and then touch the other patient. We have to keep on washing our hands. And if we have a patient who has a severe infection, we may isolate this patient in a special room. All of this is not for your memory, but I hope it makes the point on how important it is to prevent antimicrobial resistance. And this is the last slide, also not for your memory, and it is outdated, but it's okay. This is being updated every year, and the point here is that we have so many emerging uh, pathogens that are resistant to antimicrobial, and there are some priority 1, priority 2, priority 3 bacterium, and you probably discussed ESBL with Dr. Matar. You're gonna see it with me. We don't want really a carbapenem resistance bacterium. Really, this is problematic. We don't want a vancomycin resistant bacterium, etc.